So I'm going to be talking today about various aspects of allergen burden and how this impacts on both the risk of allergic asthma and how this also stratifies the management. So I'm going to briefly go through the asthma and preschool wheeze phenotypes, focusing on those that have a driving factor of aeroallergen sensitivity. Then I'm going to talk a bit about allergen exposure and what we know about allergen exposure and the development of allergic asthma. And then I'm going to focus at the end about asthma and the Allergic March and some of the interesting associations that we can see with that and some of the opportunities perhaps to prevent the development of asthma. So, asthma phenotypes. So these are the heterogeneous types of asthma that you can have. So allergen-induced, which is what I'm going to mainly focus on today, house dust mite, pollen, ragweed, cockroach and mold are the very common allergens that can increase the risk of development asthma and also can exacerbate asthma symptoms. Then there's intrinsic asthma, for which we have various genotypes, the most important of which is ADAM33, and then non-allergen induced asthma, which is not going to be the focus of the talk today. This is just another way to look at the different phenotypes based on the time when these phenotypes are more likely to occur. So, for example, in childhood, there is increased likelihood of Th2 predominant asthma, so allergic asthma, whereas in adulthood, other factors such as smoking associated, obesity associated, smooth muscle mediated. So these are other types which, again, I won't be focusing on. So what is the definition of allergic asthma? It is the most common form of asthma. Many of the symptoms of allergic and non-allergic asthma are the same, so that's why sometimes it can be hard to differentiate them. However, the main pathognomonic aspect of allergic asthma, it is triggered by inhaling allergens, usually aeroallergens. So how much asthma is atopic? If we look at the prevalence of asthma by atopy, you can see here that the percentage of asthmatics with no atopy was 2.4% in this US cohort of 6 to 59 years, whereas in those who had atopy it was 7.5%, and in the other way around, the prevalence of atopy by asthma, if there were atopic asthmatics, was 78% versus 52%. So atopy does increase your risk of asthma. I'm going to focus also on preschool wheeze and the phenotypes of preschool wheeze because I want to focus in on those that have the allergic phenotype. So we're all aware of this big cohort study that was done a while back now where they looked at the different phenotypes of preschool wheeze. You had your transient early wheezers, which presented usually with a peak wheezing prevalence between 0 and 3 years of age, followed by the non-atopic or viral wheezers that peaked between 3 and 6 years of age, and then the IgE-associated wheeze or asthma, which had a gradual increase over that period of time and generally continued into school age. So just to talk about some of the features of transient early wheeze, generally starts in infancy with reduced pulmonary function. Other risk factors include prematurity, male sex, exposure to siblings or daycare, and there's some interesting work actually looking at exposure to rhinovirus and history of bronchiolitis, RSV, and that specifically targeting the risk of increased inflammation. Prenatal maternal smoking is a known risk factor, postnatal exposure to tobacco smoke. These transient early wheezers resolve around 3 years of age, but the recent data that I mentioned about rhinovirus and RSV actually increases the risk of asthma later on in life. Non-atopic viral wheeze. These children generally have recurrent viral infections. They have normal lung function, and the origin of wheezing in these children is not clear. This is where I'm going to focus, persistent atopic wheeze. These children usually have their first episode of wheeze after infancy. They have discrete attacks and therefore are well in between episodes. Symptoms are worse at night, and they have an elevated IgE and blood eosinophilia. And I'm going to show you some data looking at this with regards to potential treatments based on this. They respond to bronchodilators and corticosteroids, whereas some of the previous phenotypes don't respond. They generally have a family history of atopy, and they have normal lung function in infancy. They then develop airway obstruction later. So this is the study that I wanted to talk to you about with regards to being able to stratify children under the age of entering school, so up until their 5th birthday, and what type of treatments will actually benefit these patients. So this was a large trial called the infant trial, where they had children that were on some form of treatment for wheezing or step 2 asthma therapy, but were under the age of school entry in the US, that is, at 5, but so up until 1 year until 4 years of age. And they looked at the benefit of using inhaled corticosteroids regularly, montelukast, or an as-needed inhaled corticosteroid. And they looked to see which of these effects was most beneficial. In this image, you can see here, in general, that those without type 2 inflammation had exacerbations and symptom control with no clear treatment preference with regards to either inhaled corticosteroids, montelukast, or as-needed inhaled corticosteroids. But if they had type 2 inflammation, so the persistent atopic wheezes, with inhaled corticosteroids, they had fewer exacerbations and improved symptom control. And which were the biomarkers that were helpful in predicting this response? So they looked at this in this cohort, and they looked at whether you had raised eosinophils or whether you were sensitized to any aeroallergen. So if neither were present, no raised eosinophils and no sensitization, there was no difference in the response of as-needed inhaled corticosteroids, regular inhaled corticosteroids, or montelukast. If you had raised eosinophils, there was a slight increased best response with daily inhaled corticosteroids. This was also slightly increased if you had sensitization to aeroallergens. But if you had both raised eosinophils and sensitization, there was a significant increase in best predictor, so in best improved control of your symptoms if you were using a daily inhaled corticosteroids. So in terms of stratifying the management of these patients, if you're able to identify those children with preschool wheeze that have the atopic features, then they are more likely to respond to inhaled corticosteroids on a regular basis under the age of 5. So moving on to the second part of my talk, allergen exposure and asthma. So we all know, based on the definition of allergic asthma, is that allergens are an exacerbating factor for allergic asthma and lead to asthma exacerbations. However, what is the evidence that allergens increase the pathogenesis or lead to the pathogenesis of asthma? So this is some data from the Isle of Wight study looking at the risk of various allergic diseases based on positive skin prick test reactions. So you can see here that there were 790 children that were followed up, and they were followed up for the outcomes of asthma, which is in the small diamond, rhinitis, or eczema, or any allergic disease. And you can see here that for asthma, which is the second from the bottom, as you increase the number of positive aeroallergens, so you increased the likelihood of asthma. And we also know this from many other studies where they've looked at, in particular, house dust mite exposure and the increased risk of asthma. The very first one was by Sporic et al., where they found a cutoff of 10 micrograms per gram, which was a sort of a threshold level of house dust mite exposure that significantly increased your risk of asthma. The Isle of Wight study also showed this in their cohort. So if there was a house dust mite sensitization, then your risk of asthma development was 8-fold. So the obvious thing would be to reduce house dust mite exposure, and that should prevent the development of asthma. We know that, for example, children who have asthma, if they're taken to the mountains at very high altitude, where there's very little house dust mite, that they have much improved symptoms of their asthma control. So you would think that taking house dust mite exposure away would also improve asthma control. There's been a huge body of evidence on this, looking at whether you can reduce indoor allergen exposure and whether that leads to reduction in allergen-specific sensitization and a reduction in the development of asthma. Unfortunately, most of these studies have been unsuccessful. The main study was by Adnan Kustovic group, the Mars study, the Manchester Asthma and Allergy study, where they did very stringent control of house dust mite, and they randomized a large group of children to either house dust mite reduction measures or no reduction measures. And they actually found that the children in the house dust mite reduction group had an increased rate of house dust mite sensitization. So it did not work. Why did it not work? So there's a few reasons for that. So we know that in all associations, there is the chance of having a bell-shaped curve. So essentially, if there's no exposure, you have very low risk. If there's very, very high exposure, you have very low risk. And if you have anything in between, you have an increased risk. So what happens if you reduce exposure? You basically take the ones in the middle to the bottom, so they reduce the risk that they have, but you take the ones at the top into the middle, and that then increases their risk. So overall, the net effect is not significant. And that is one of the problems when you're trying to address environmental exposures in an effect that has a bell-shaped curve. There's another aspect, which is that you don't just have house dust mite in your bed, but you also have some protective factors like endotoxin. So endotoxin is basically a lipopolysaccharide, and it is part of the farming or the hygiene hypothesis, which is essentially that being exposed to bacterial products during the first year of life, first few years of life, reduces your risk of allergic sensitization. So when you reduce house dust mite in your bed, you also reduce endotoxin. So potentially you're reducing both, and therefore you're not actually having a net benefit. Finally, there are also lots of individual aspects with regards to the person. So if you have one type of genotype, you may respond very well to a certain intervention, whereas if you have another type of genotype, you won't respond well. And this is called the gene-environment interaction. And essentially there's one which is very well known for this specific thing, which is that you can have different polymorphisms, alterations in gene mutations in the lipopolysaccharide receptor, which is the receptor for endotoxin. And then if you have exposure to endotoxin, you either benefit from that or you don't benefit from that. So unfortunately, doing sort of an overall reduction in exposure in these situations has not improved the risk of development of asthma. So, Cochrane reviews, which have looked at house dust mite reduction measures to prevent asthma, have shown that it is not successful. So we do not recommend house dust mite reduction measures to prevent asthma. What about recommending house dust mite prevention measures in a child who has house dust mite sensitization and asthma? Will that help their asthma control? Cochrane review has looked at the available evidence, and the answer is no. So we do not recommend house dust mite reduction measures in children who have asthma, who have house dust mite sensitization. But what I would say is that often they also have allergic rhinitis and house dust mite allergy. And in those patients with severe or moderate to severe allergic rhinitis and house dust mite sensitization, extensive house dust mite reduction measures may improve their symptom control. So there's a bit of a caveat there. And then generally there's not that much evidence for pet dander. We know that exposure to cats and dogs, if you're sensitized to those and you have asthma, can trigger your asthma. But we don't have any trials looking at removal of pet from the home and to see or rehousing to see whether that improves asthma control or prevents the development of asthma. Okay, so there is some hope on the horizon with regards to allergen reduction. So Aeroallergen is a machine that you put over your bed, and basically it has a way of adjusting the temperature so that it cools the temperature that goes onto your breathing area by a very small amount, so you hardly notice it. What this actually does is that it stops the convection of the body, which then the convection promotes an allergy environment, because every time you turn, you basically raise all of the house dust mite from the bed and you inhale it. And so on the basis of this technology, it prevents that from happening, and then you have this allergen-free zone. Now, the main body of evidence from this is a study that was done by Bob Boyle, looking at 312 children and adults. This was done in 2012, so it's a while back now. It was powered to determine improved quality of life, and it did show improved quality of life, which was more significant based on how severe the child or adult's asthma was. However, in this study, they did not show a significant reduction in asthma exacerbations or the potential to reduce medication. I would, however, note that this study was not powered to show this. And since then, there's been a small study of about 80 adults, an observational study by the German Asthma Network that did show a reduction in exacerbations. And there is an ongoing trial called the LASER trial, which is in 222 adults in America, that is looking at whether this reduces asthma exacerbations. Because this is very important in terms of justifying this for quality of life measures and NICE guidelines. So they don't just want quality of life, but they also want reduction in exacerbations. So this is a post-hoc analysis which was done with regards to showing that the more severe asthmatics benefit more from this AirSonet treatment. So you can see here that in the intention to treat group in all, there was no significant reduction in severe exacerbations between the group that had AirSonet and those that did not. If you had a reduction in your asthma control test, so less than 18, which Rosa just mentioned now, is indicative of severe asthma, then there was a slight difference in the two groups. But just going along the GINA step 4, so the more severe asthmatics, then combining ACT and GINA, and then combining ACT, GINA, and more than one allergen, you can see here, did show a significant result. So if you do have aeroallergen sensitivity and you have severe asthma, then even in Bob Boyle's study, there was a reduction in severe exacerbations, although I note this is a post-hoc analysis. Okay, so that's the second part of the talk. So we're going to move on now to asthma and the Allergic March. So we all know that when we're in a pediatric allergy clinic, we generally see this type of patient that has severe eczema, then go on to develop food allergy, allergic rhinitis, and asthma. And we're seeing very few children now with just one type of allergy, especially if they had eczema early on. So what is it that links all these things together? So this is a study looking at a systematic review of many different studies with the association between eczema under the age of 4 years and then the development of asthma by 6 years of age. And you can see here that the range of asthma in inpatients ranges from 33% to 52%, in inpatients and outpatients up to a maximum of 45%, and in outpatients 45%, which is higher than the known rate of asthma. So having eczema does increase your risk of asthma. And we also know that genetic and environmental factors contribute to eczema, food allergy, rhinitis, and asthma. But what I want to just discuss for a little while is whether perhaps this is what's happening, and that it's the child who has eczema who then leads to having food allergy, rhinitis, and asthma. And you're probably all aware of the link between eczema and food allergy and the various studies that have looked at cutaneous sensitization in food allergy. What about the chances of cutaneous sensitization for aeroallergens for rhinitis and asthma? So this is a study that was done in French infants with eczema, and they looked at sensitization to house dust mite allergens, cat, dog, cockroach, birch, or ragweed. And even under the age of 1, so mean age 7 months, 30% had an IgE of more than 0.35, and 16% had a skin prick test of more than 3 millimeters. And this was not the case in children who had eczema. They also looked at transepidermal water loss, which is a way to measure a disrupted skin barrier. And it basically shows that you're losing a lot of water in your skin, and your skin is generally very dry. And it is known that a raised TEWL increases your risk of eczema. So raised TEWL often happens before you develop eczema and is one of the risk factors for this. And even in this group, when they looked at raised TEWL, they found that it was associated with a greater number of aeroallergen sensitizations. So a disrupted skin barrier was related to increased number of aeroallergen sensitizations, and we know that that increases your risk of asthma. And then they looked at these children and they monitored what happened over a period of time, and they found that aeroallergen sensitization in these children with eczema rapidly increased by the time they were 2 years of age. And you can see here that specifically for house dust mite, and we know that it's house dust mite that is the highest risk for asthma, between 60 and 70% of these children had a positive IgE to house dust mite, and between 45 and 67% had positive skin prick testing, only at 2 years of age. So this is happening very early on. So, what is the risk of later onset of disease in these children? And in this study, they looked at the predictor of early eczema and the development of allergic diseases. So they looked in Norway at allergic diseases at the age of 6 years of age in children with either no eczema or with eczema at 2 years of age. And in figure A, you can see these were the children who had eczema at 2 years of age. Their risk of asthma by 6 years of age was 10.6, and rhinoconjunctivitis was 27%. Whereas if they did not have eczema at 2 years of age, by the time they were 6, asthma was only 4.4 and rhinoconjunctivitis was 8. And they found that if eczema was early in onset, i.e. less than 3 months, then this had the highest risk factor for asthma. And we also see this in food allergy. In the Tasmanian Longitudinal Health Study, they also showed that childhood eczema was associated with new onset asthma, not just in pre-adolescence and in adolescence, but also in adult life. So onset of asthma could happen even in adulthood if you had early eczema. So the allergic march continues well past childhood. Finally, looking at another measure of skin barrier disruption. So the filaggrin gene, which I've mentioned, is one of the polymorphisms that you find in the population, that if you have a mutation of it, then you'd have a disrupted skin barrier. And it increases your risk of having atopic dermatitis or eczema. So if you had filaggrin and you had atopic dermatitis, you can see here that your risk for asthma increased 2.79-fold. Interestingly, if you did not have eczema, but you had filaggrin mutation, it did not increase your risk. So this would seem to suggest that you need both the disrupted skin barrier and inflammation to lead to asthma. So to summarize, for these findings with filaggrin, you need to have both eczema and filaggrin. So generally, we believe that you have a filaggrin mutation and then it's things in your environment that predispose you towards eczema. So perhaps having filaggrin non-mutations and things in the environment, such as raised house dust mite and other factors, can increase your risk of eczema and asthma. And this is just a nice model looking at the combination of this hypothesis. So genetic predispositions such as filaggrin null mutation and environmental factors such as breastfeeding, infection, sensitization, or food allergens can lead to childhood eczema with a defective skin barrier. You then have allergen entry through this defective skin barrier, leading to epicutaneous sensitization. Your Th2 memory cells then migrate to the nasal and bronchial lymphoid tissue and sensitize the airways. And then on re-exposure of your airways, you can have asthma symptoms or allergic rhinitis. And this is a proposed pathway, which is just interesting, something to think about for the future. So to summarize, we've talked about various aspects of the allergen burden in the development of allergic asthma. So we know that allergen sensitivity is important in both preschool wheeze and asthma, both as a predictor of the disease and also as stratification for management. If you remember the infant trial where they looked at either inhaled corticosteroids, montelukast, or as required inhaled corticosteroids, they showed that if you had raised eosinophils so raised eosinophils and sensitization to aeroallergens, that you benefited from an inhaled corticosteroid. The evidence for allergen exposure reduction is not great up until now with regards to house dust mite reduction measures, but there is some interesting data on Airsonet, and I'm hoping that with the laser trial and some other data in childhood that will be a stronger evidence. At the moment, it's quite difficult to get Airsonet for NHS patients. It is up there at the step 4, step 5 level, and they want to have some trials comparing omalizumab to Airsonet. So it is quite difficult at the moment, but I think that it is a very interesting area and may benefit patients. And then finally, I just wanted to give you an interesting debate about the potential role for cutaneous sensitization for respiratory allergens and the role that this may have in asthma. Thank you very much.